Welcome to this video on anterior segment examination using the slit lamp. So we have a patient in which we see a hypopyon and there is corneal ulceration. Well, there is another interesting finding in this patient as well. Let's see if you can figure that out. Let's go through the different steps. So here is the hypopyon, which seems to be slightly layered. It doesn't going to be not producing that total area of a level which you see in a typical hypopyon, in which you will see typically going like this over this. So there can be two reasons for that. One is if the patient is been lying down and the hypopyon is very thick, it might not, the fibrin is more in that, it might not assume that layer until a longer time. Or the other thing could be there is posterior synecdoche in this area in the periphery that is not causing that hypopyon to show up clearly. The second thing which you're seeing is this corneal ulcer. So the corneal ulcer has got two parts to it. If you look at this, so this is the area which is more dense and this is the area which is less dense. So this is where the activity is going on in this patient. And the other thing which you see is this discontinuation of this opacity over here, but the active ulcer is over here. And then there you see a faint shape opacity over here as well. And these dots over here. So what is this area? This is actually an area of band keratopathy. So actually this patient had band keratopathy on this side and on the nasal side as well. And there was an area where the epithelium had broken off and this patient developed an area of infective keratitis along with formation of a hypopyon as well. And you can see ciliary congestion and diffuse corneal congestion in this area. The other thing which you can see, this patient has got a peripheral iridectomy as well. So most probably there's a possibility that there could be a trabeculectomy bleb to be visible in this patient. Let's go ahead and see what the findings which I've shown you, try to understand them when we do a slit lamp examination. In order to find the depth of the ulcer, we'll have to go through a higher magnification slit lamp examination of this ulcer. You can see the finding or the corneal reflex is pretty dull in this patient because of the corneal ulceration. This is the slit beam. This was diffused. We go to a higher magnification and look at the ulcer in detail. So what actually happens in an ulcer is normally in the center you would have that dead-ish tissue where the fight actually has subsided or is subsiding, while this is the active area. So other thing which you want to see, is this a fungal ulcer? If that was, you will see satellite lesions going around. But you do see some areas of spots over here. Are these satellite lesions? Well, they were not. They were actually an area of mutton fat capes which were available. So that which was seen in this patient. So let's go forward and see ahead. See, this patient had a corneal ulcer which had induced enough keratitis to produce a hypopyon, Keratic Precipitates, and that was what you were seeing in this patient. Let's go and quickly have a look at the other eye of the patient to see that this patient also has some area of, what do you see over here? This is an area, interesting enough, this is an area of a desmatocele over here along with this area. This seems to be like band keratopathy over here. Let's get a clear view of what we're seeing and go forward on this. So it's important to compare with the other eye in both patients. The other thing which you're seeing is this is an area of oval pupil. Yes, we have band keratopathy which is present over here. You see these clear areas. This is area where the nerves are going through the cornea in the Bowman's membrane. That is why you see that area. And band keratopathy can be due to various reasons. You can be chronic uveitis which can produce that. Patients who have silicone oil in that, they can have that. Post trauma, they can have that. So there are different causes for that. So you need to figure out what the cause is. But it is important to identify what you're seeing and how it is affecting the patient as well. The other thing which you want to do is then make a slit beam and then to actually judge how thick or how thin the cornea is. So this patient was pseudophakic as well in this. So this is the area of band keratopathy which I'm highlighting. by asking the patient to look over to the temporal side. So thank you very much for watching.